My name is Rafat Abonour. I'm a professor of cancer research at Indiana University School of Medicine. It is really a great time to be a myeloma physician today because when I started working on multiple myeloma, we had zero drug approved for treating multiple myeloma, and patient lived about 2 to 3 years. Now we have more than 20 drugs that are approved for treating multiple myeloma. And the recent approval of both bispecific and CAR T cells really changed the way we look at the future of patients with multiple myeloma. I'm repeating a quote from one of my colleagues, Dr. Ken Anderson from Dana-Farber, who said, myeloma patients should live their life and die from something else, not from myeloma. And I think hopefully we can cure a large number of patients. As you know, myeloma patients tend to relapse, and today induction treatment is outstanding. We have 4-drug induction regimen followed by transplant and maintenance. And a lot of these patients do well for sometimes, and fortunately, they will start relapsing. And for relapse setting, we had also a good combination that we've been using for a while. But the question is, can we improve on that? Most of the treatment we offer our patients, the patient needs to be on therapy for a prolonged period of time. We know that CAR T cells have been approved for the management of patients with multiply treated regimen. And so the question is that can we use these CAR T cells, such as Ide-Cel, early in the second relapse or beyond? And KarMMa-3 study was designed to say, okay, is it better to give patient CAR T cells versus a standard salvage therapy? And the standard salvage therapy is different between countries. Some will include carfilzomib and IMiD. Some will have proteasome and monoclonal antibody. So the design of the trial reflected the sort of the standard of care of these countries, including the US. And the KarMMa-3 study was a large study. With the hope is CAR T cells one and done better than continuation of therapy? So what happened is the patient were randomized 2-to-1. 2/3 of the patient got the Ide-Cel and 1/3 get a standard regimen. And the patients were treated with 2 to 4 lines of therapy and stratified based on age, number of prior cycles, and high-risk cytogenetics. And the primary endpoint was really progression-free survival that is documented by external review committee. So what happened? I think the number one is that who were the patients that included in this trial? And basically, the patient included in this trial were your typical relapse patients. So the median age was about 63. The median years from diagnosis was about 4 years. And what's interesting is that a large number of patients, about a quarter of the patients, had extramedullary disease, thus are the difficult patient to treat. And almost 60% of the patient had high-risk cytogenetic. And also, a quarter of the patient had what we call ultra-high-risk cytogenetic. So basically, not your average patients were enrolled on this trial. Those patients were high-risk extramedullary disease, heavily pretreated patients. So the nice thing about the trial is that the progression-free survival endpoint was met. The median for the patient who received Ide-Cel was 13.8 months, and for the patient who received the standard of care was 4.4 months. And at 18 months, 41% of the patient was still without progression in the Ide-Cel arm versus 19% in the standard of care arm. And if you look at the responses were incredible. If you look at the depth of response, the overall response rate in the Ide-Cel arm was 71%. In the standard care arm was 42%. But the most important thing is that the complete remission rate was much higher, 44% in the Ide-Cel arm versus 5% in the standard arm. And the MRD negative CR was also higher, 57% versus, I'm sorry, 57 patients or 35% of the patient versus 2% in the standard arm, 35 versus 2. Clearly, what you're getting here is that you're getting higher rate of response rate, but also quality response and deep response. So, the other question is that, now we have some overall survival data trying to mature. But really what we need to remember is that not everybody who is assigned to the treatment get treated. I mean, if you look at the patient in the Ide-Cel arm, 11% did not get the Ide-Cel arm, and there was some also crossover. So if you do, sort of sensitivity for crossover adjustment, the overall survival was in favor of the Ide-Cel arm, 41.4 months versus 23.4 months for the patient who received standard of care. So again, I mean, I think this is very encouraging results that suggest that CAR T cells can be an ideal for patients who do not choose to stay on therapy for a prolonged period of time in the standard arm. And you're getting better responses and what appear to be an overall response rate improvement. So were there side effects? Yes. I mean, there's adverse reaction that has been reported in the trial. And it is familiar now to us, in terms of the side effect, the cytokine release syndrome did happen in 47% of, I'm sorry, in 88% of the patients, but grade 3 and 4 happen only in 4% of the patients. Neurotoxicity happened in 15% of the patients. Grade 3 and 4 was in 3% of the patient. There was also increased risk of infection. 56% of the patient had some kind of infection, and 22% of the patient were grade 3 and 4. With the follow-up on this study in terms of second primary malignancy, the rate was only 1%. Most of the deaths were related to disease progression, and about 6 and 7% on each arm were related to adverse event. So I think my take on KarMMa-3 and the new approval for Ide-Cel in the second line and beyond is that this is a treatment options that are available to our patients. Does provide excellent control of the disease. It does prolong progression-free survival, and there's some suggestions that a patient who received the treatment had a better overall survival. So I think, when we see a patient now with second relapse of multiple myeloma, this option is available to them. And we will discuss with the patient the risk and the benefit according to each regimen. And hopefully we will make the right decision for the right patient. From a nursing standpoint, I think our nurses are familiar with the side effect of chemotherapy, the infusion. Nurses deal with that day in and day out. Similarly, the nurses who are taking care of patients on going through CAR T cells are now familiar with identifying those who have cytokine release syndrome, what grade the cytokine release syndrome, and how to report and manage these side effects. Also, the neurotoxicity. I think it's very important that the CAR T cells patient, when they leave the hospital, they need to be followed mostly for infection related complications. So you need to know that the patient may need intravenous immunoglobulin, IVIG, monthly for a while. You need to put them on prophylactic antibiotics such as acyclovir and maybe sulfa drugs to prevent PCP, pneumocystis carini. And so when the patient's in the Ide-Cel arm had a fever, they had infection until proven otherwise also. So we need to make sure that's, after they leave the hospital, after the 28 days. So I think, late CRS doesn't happen. Late neurotoxicity usually doesn't happen. Most of the complication in the outpatient setting after the first months usually related to infection. But we also have to be aware that, we're still learning about, CAR T cells. So any unusual symptoms need to be, investigated promptly and reported also promptly. I mean, I really think, it's a great time for, myeloma patients because we have better treatment that produce deep responses, lasting responses. Patients who have extramedullary disease, patients who have high-risk disease are responding and doing really well. So I'm so grateful to be in a position to witness these drugs and their impact on the quality of life of our patients.